Thank you so much for the invitation.
No?
I'm so sorry I couldn't make it, but the bird strike yesterday made the aircraft was impossible to fly. But next year, I hope it will be possible. I think it was the third time I could not come. Now it's about time. I was looking forward to it. So, what I will do now for our case discussion, I will give you some tools in your hand to better understand what we radiologists are doing, what nomenclature we are using, because that's important to understand and the reports and also know the limitations of the of CT. So yeah, we always try to tell you about the strengths, but there are also limitations, and that's what we're going to do as well today. These are my disclosures here. Okay, so we saw similar classification already on the interstitial lung diseases or diffuse parenchymal lung diseases, you may also call them. And importantly, and I can be quicker here because you heard so much already about that, some of them may show fibrosis, signs of fibrosis, and some of these may also then progress. And what is always important to know about the differential diagnosis is the distribution and the prevalence of these diseases. And also this is something you already heard. IPF is the disease which got most of the attention until very recently because it's the deadliest form of fibrosing lung diseases. And if you go to the guidelines of pulmonologists, much what we discuss is centered around IPF. So all these guidelines you will hear in about UIP and NSIP, this is centered around IPF. And you have to be aware of that because some criteria don't fit that well to RA-ILD, as an example, which does also present with a UIP pattern, but it's not completely similar sometimes as like in IPF. But that's for historical reason. Then also sarcoidosis and hypersensitivity pneumonia are very important for us radiologists and for pulmonologists and patients alike, because they have quite a variety of manifestations, CT manifestations, and are very important also from a differential point of view. And what cannot be emphasized enough, we need to work together because CT alone is not diagnostic for any disease. It is an important diagnostic clue, but we have to combine our information. We have to join forces here to come up in a multidisciplinary discussion to diagnose the underlying disease and treat patients accordingly. And what we try to do is we try to avoid biopsies. Yeah, this is quite striking because if you think that IPF has a prognosis which is worse than in most tumors, why don't we just biopsy? Because all the definitions you hear about, the UIP, the usual interstitial pneumonia, non-specific interstitial pneumonia, these are pathologically defined entities. This is not radiology. But we use in radiology the same nomenclature as we try to predict the result of a sufficient biopsy. And we perform nowadays biopsies, in particular if the CTs are inconclusive or there's a discordance between the clinical and the imaging findings. Before I get into that, just a brief reminder, what is lung fibrosis? And you see up here, that's a normal lung tissue. And down here, that's a patient with a UIP pattern. And you see the scarring of lung tissue. And it's the consequence of a chronic or repetitive injury of the lung tissue. And in many cases, it's idiopathic, but very frequently in the context of a systemic disease or an allergic reaction. And the problem is that some of these fibrosing lung diseases may progress, which leads then to an increased mortality. And just briefly again, why don't we biopsy then if that's so important to get to a diagnosis? Because the alternative diagnoses require different therapies. But the problem is that these biopsies can be risky because patients are compromised in their respiratory function and they suffer from comorbidities. And then there's another very important point here, which is shown here in this patient. This is a patient who underwent lung transplantation, and we knew in advance that this patient has a hypersensitivity pneumonia. And I asked my pathologist to take the lung and take samples from different areas of the lung. because I wanted to show you what was found. So in some areas, the pathologist could diagnose hypersensitivity pneumonia. We knew that. But in other areas, the distribution of this interstitial inflammation was not so typical for HB, and the patient would have, the pathologist would diagnose then non-specific interstitial pneumonia. In other areas, a UIP pattern was found, and yet at the apical parts, a particular subtype of fibrosis called pleural-parenchymal fibroelastosis was diagnosed. And the reason why I show you that is that biopsies are prone to sampling errors. And this is also why we discuss these cases then also after a biopsy in the multidisciplinary team. This is not oncology where the pathologist gives you the diagnosis. This is much more difficult in our day-to-day life. And then there's this risk of exacerbation. If you biopsy a patient with a fibrosing lung diseases, a substantial number of patients will show a rapid progression of disease, rapid deterioration of the symptoms, as shown here in this patient on the right side, the deterioration here on the right side. This patient needed to be transplanted because it was just a biopsy performed for this lung fibrosis here on the left side, and the deterioration led to the transplantation. So that's something we see in fibrosing lung diseases, and this is one of the main reasons we try to avoid biopsies, and we try to predict the result of a biopsy by using CT. So CT is the starting point here in our diagnostic workflow. And as you can see here, these images look very similar. And it's not just for you, but also for radiologists. And that's why we need a systematic approach. We follow always a certain structure, a certain pathway to come up with a diagnosis. And it all starts with the analysis of the lung parenchyma itself. And we call this the pattern approach. We describe the distribution of changes in lung density, and they have specific names, and I will get to that. These are the so-called patterns. And CT is all about measuring density of lung tissue. So lung tissue consists primarily of, if you look here at the histology, consists primarily of air. Just a minor part is parenchymal cells and vessels. And any change in the relationship here will change in density, changes in density. And we have a specific nomenclature for that. And in essence, it's the increase in density, and I will get to that, which is ground glass, consolidation, and atelectasis. No worries, I will get more detailed into these features. Then this increase in density can be very, very focal. We call it then a nodular pattern, or give you the impression of a network, and we call this then a reticular pattern. And last but not least, also the density can be decreased, as we see in cysts, emphysemas, and cavities. So if you go now to such a normal pattern we see in fibrosing lung diseases, one of the hallmarks we see in fibrosing lung diseases is ground glass. And ground glass gives you a hint that you might be dealing with a disease which is triggered by inflammation. I mentioned already, fibrosis can be the consequence of a chronic repetitive injury, meaning inflammation also. And inflammation may lead to this increase in density. This in the ventral part here, this is how the lung should look like. And here in the dorsal part, you see it's denser, it's more gray, but you still see vessels. And by definition, this is ground glass. But the problem is, from a radiological point of view, I'm not able to tell you if the ground glass I see is reversible. And this goes back to the question which arose previously, do we have a clue on a CT if this will respond to anti-inflammatory drugs? And the answer is not really. Also in NSIP, in scleroderma, we can't really do that. Look here, these are two different patients, one with a completely reversible disease, one with a lung fibrosis prior to lung transplantation. And I would not be able to tell you which one is which. In fact, here, patient on the left side, this was pneumocystis cerevisiae pneumonia, completely reversible. This was a patient with a connective tissue disease associated NSIP prior to lung transplantation. This is very important to know. Ground glass is not specific for fibrosis. You see it in many other entities. The other main pattern we see in fibrosis are reticular abnormalities, as you can see here in this patient, all these crisscrossing lines here. This is more commonly than not caused by fibrosis, but be aware it is also not a proof of fibrosis. Just to show you that, another case here, if I show this case to a radiologist, I can guarantee you that most of the radiologists will diagnose here a fibrosing lung disease because it looks like one. It's reticular, some ground glass, and you see also some dilated bronchi. But this was a patient undergoing chemotherapy. This was a patient presenting with acute symptoms. And this was a completely reversible disease. This was bleomycin-induced lung toxicity. And this brings me again to this important point of cooperation. You have to give your radiologist the main information he needs, and the type of presentation is super important for us. But we do also look for signs of fibrosis on our HRCTs. There are a number of features which can lead us to the diagnosis of a fibrosing lung disease. But we also look for other signs which are not parenchymal signs. We look for traction bronchiectasis, and I will get to that in a second. Pleural thickening, leading to this, giving us a hint that we might be dealing with a systemic disease, or pleural plaques leading, pointing towards asbestosis, pericardial effusions or pleural effusions, dilated esophagus, and many features more like lymphadenopathy are additional points to show us, to bring us to the differential diagnosis. But when it comes to fibrosis, there are a few things which are pointing towards fibrosis. And fibrosis is scarring of lung tissue. And as with other scar tissues, this leads to a loss of volume. And this can already be appreciated on chest radiographs here. If you look at this chest radiograph, you see that there are some reticular abnormalities. There's too much density, in particular in the basal parts of the lung. And if you're familiar with chest radiography, you will see that the diaphragm should be here at this level. So the diaphragms are too high. So you don't know if the patient did not take a deep breath because he didn't understand the technician. But if you look here at the lateral, it's also here an elevation of the diaphragms, which gives you a hint that this is not just because the patient did not listen to the technician. This is presumably because there's a loss of volume. This effect of scarring you see also then in the lung parenchyma. Look here, this is a bronchus which should be tapering towards the periphery, should get smaller and smaller, but it remains the same, and it shows these varicose borders. And this is what we call bronchiectasis. And if you look at the surrounding lung parenchyma, you see the parenchyma findings of fibrosis, ground glass and reticulation. And so you now know that this is so-called traction bronchiectasis, as this is a disease, this points towards fibrosis. What is really important, the surrounding parenchyma has to be either ground glass or reticulation. If it's normal, then it's a bronchial disease. If it's a consolidation, you have to be careful. And this is important for you as rheumatologists. Just let me show you a case here, a patient presenting with acute symptoms. And this was 2 weeks after after he was admitted to the intensive care unit. And my rheumatologists and clinicians from intensive care asked me if this is an irreversible disease or reversible disease, meaning should this patient be transplanted because that's fibrosis, or is this something which is worthwhile waiting? And the clear answer here you can give is, I don't know. Because the presentation was acute and the parenchyma surrounding these airways is very, very dense. This could be reversible. And this turned out to be organizing pneumonia, as you can see here in the follow-up. So again, always look at the clinical context. Otherwise, you might end up in a wrong diagnosis. So then also the features of fibrosis can be seen on a CT scan. I will not get too much into detail here, but we radiologists look also at the position of the fissure. If the fissure is in the anterior third of the diaphragm, at the anterior third of the chest, at the level of the diaphragm, then it's a normal volume. And if you look here, this is something we observe frequently in scleroderma. The lower lobes are more involved, leading to a significant shrinking of the low lungs. As you can see here, there's the position of the fissure in a patient with systemic sclerosis. This is indicating a significant loss of volume. The most important feature for us radiologists indicating fibrosis is honeycombing. And honeycombing is the final proof of fibrosis, if you will, and develops out of these areas of reticulation, as you can see here in this patient. And someone was reminded here of the honeycombs of bees. That's why we call this honeycombing. And if you look here at an explanted lung, this is honeycombing. To see here this cystic air-filled structures. What is important here that the neighboring cysts are sharing their walls. Then you can talk about honeycombing. And honeycombing is of very much importance for our differential diagnosis, as we can most usually see it in UIP and fibrotic hypersensitivity pneumonia. And last but not least, the main clue to the differential diagnosis is then distribution. Distribution helps us then to narrow the differential diagnosis even further. So if you see a basal predominance, then you findings you consider primarily usual interstitial pneumonia and non-specific interstitial pneumonia. In UIP, you see the honeycombing or reticulation, whereas in NSIP, you primarily see ground glass, but there is a significant overlap, and I will get to that. And then in fibrotic hypersensitivity pneumonia, you require a random distribution, sometimes a mid-zone distribution. And in other cases, like in fibrotic granulomatous diseases, you see an upper lobe predominance. And these are all clues to the differential diagnosis we need to diagnose our patients. Let me show you a few cases before we go into the case discussion with Vanessa, and then afterwards I will show you some more cases and discuss that with you. This is a patient who presented with signs of a connective tissue disease. And I usually don't get that much information from my clinicians, so I will not give you much more here as well. But if you click through these pictures, then I will show you the hallmarks of that patient here so that you can appreciate how we radiologists are thinking. I walk you through the pictures first so you get an overview of all these findings. And as you can see here in this patient, there is normal lung tissue. It should be as dark as this one here, but then there is also this more gray appearing areas where you still are able to see vessels. And by definition, that's nomenclature, we call this ground glass. Ground glass can now be, and viral pneumonia, as we discussed before, can be caused by edema and many other things. So we have to look for signs of fibrosis, which are traction bronchiectasis, loss of volume, and honeycombing. And if you look here, you see these dilated airways here. So we can call this traction bronchiectasis and thus the lung fibrosis. And in this distribution, the basal predominance, subpleural predominance, sometimes there's some sparing of the subpleural space. This is what we call a non-specific interstitial pneumonia pattern. This is a pattern which is very frequently found in connective tissue diseases, but in and of itself, it's not diagnostic. We accept that diagnosis only if it's seen in appropriate clinical context, meaning in patients with connective tissue diseases. If this would be seen in a patient without that background, we would consider a biopsy because there are also differentials to that, which I will not get too much into that. Smoking-related diseases may also look like that. So it all depends on the clinical context. So what are now, if you summarize that, the clinical features here of NSIP, we see as a CT pattern, ground glass, and a variable degree of reticulation in combination with a lower lobe volume loss and traction bronchiectasis, and the distribution is basal and peripheral. Importantly, there is also quite a variation in the reticulation. In some patients, we just see ground glass. In others, we see just reticulation. And then yet in others, you see a combination of both. And this then leads to an overlap with other features, other fibrosing lung diseases. This is important to know. Another important disease is shown here in this patient, and I will continue on then with this, a similar case later on, a 71-year-old patient with known lung fibrosis for quite some time. And if you walk now through these pictures, you will appreciate that this looks similar but still different. You see a lot of ground glass. In fact, almost everything is ground glass you see here, but it's not in a basal predominance. It's everywhere. And in addition to that, I see here these cystic air spaces. And if you recall it, that's what we call the honeycombing. And in this distribution here, I would consider here another disease, which is hypersensitivity pneumonia. You see here more nicely shown, if you look from the side, you see here this mosaic attenuation, what we call it, this patchy distribution of of density levels here throughout the lung parenchyma. And this looks different to what I showed you before. How does this happen? Now, this is what we call hypersensitivity pneumonia. It's an exaggerated immune response. Very common disease, leading to this lymphocyte proliferation. But lymphocyte proliferation is something we see also in connective tissue diseases, so that in and of itself does not make the diagnosis. For the pathologist, these purely formed granulomas are the very important feature. And another thing, distribution, also for pathologists, because that's a disease which arises from allergic reaction, and these antigens are inhaled and lead to a bronchiole-centric inflammation, in contrast to NSIP, where this distribution is more diffuse. This is, however, also a feature we sometimes see in hypersensitivity pneumonia. This is where pathologists then struggle. If this inflammation is more diffuse and they don't see this ill-defined granulomas, then they would diagnose NSIP. This inflammation may also lead to a narrowing of the small airways, and this is what then we and the pulmonologists call air trapping, leading to this retained air within the small airways. And this is what we see, like an example here in a patient with hypersensitivity pneumonia. You see here this inflammation, this bronchiole-centric inflammation with these nodules I showed you before as a hallmark of hypersensitivity pneumonia. Another hallmark is this here. You see these dark areas. The patient performed an expiratory scan. You see these dark areas. This is what we call air trapping. And this is another clue to a small airways disease, which is the most common feature here. Most common disease would be hypersensitivity pneumonia as a diagnostic clue for us that we are not dealing with NSIP. So the features here are a combination of a parenchyma disease and a small airways disease. And this leads us to the diagnosis. Again, this is not something which is diagnostic in and of itself, but in a combination with the clinical context, we can avoid biopsy in many, many cases. So we see a combination of these nodules and air trapping with ground glass and traction bronchiectasis and honeycombing if it's a fibrotic form. And the distribution here, also super important. It is more diffuse, involving whole lungs, but hypersensitivity pneumonia is the biggest chameleon when it comes to fibrosing lung diseases. So even the most beautiful non-specific interstitial pneumonia can later turn out to be hypersensitivity pneumonia. So that's why your radiologist will probably always say, I can't exclude hypersensitivity pneumonia, because based on imaging, you can't. I just can point towards that if I see a small airways disease. And then there is so many manifestations. I showed you already here a couple of different diseases which can mimic almost any other disease. I think I will stop here and move on with the other types of fibrosis in my second part. And now we move on to the discussion with Vanessa.